The PRAISE-2 study looks at the effect of amlodipine on the survival of patients with severe chronic heart failure due to a non-ischemic cardiomyopathy. Patients were randomized into either amlodipine or placebo groups. The study did not indicate how randomization was performed. In both groups, the patients received their usual medications. If the patient experienced an adverse effect, the amlodipine was reduced or discontinued. Allocation concealment was not indicated. The study was double-blinded, however there was a safety panel that periodically looked at the unblinded results. An intention-to-treat analysis was performed, and the study was not stopped early. The median follow-up was 33 months. There was 122 patients in the placebo and 120 patients in the amlodipine group that quit the trial. Loss to follow-up was not indicated. This table indicates that the starting characteristics between the two groups were similar. The mortality rate was 278 out of 827 people for the amlodipine group and 262 out of 827 for the placebo group. The hazard ratio indicated was 1.09 with a confidence interval of 0.92 to 1.29. This passes a line of no difference. As well, in the subgroup analysis below, all the confidence intervals also pass the line of no difference. The hazard ratio for cardiovascular death was 1.14 in the amlodipine group versus the placebo group, and the confidence interval is 0.95 to 1.37. This also passes the line of no difference. Looking at the hospital admissions in amlodipine versus placebo group, there was 505 patients admitted for a total of 1,433 admissions in the amlodipine group versus 529 patients for a total of 1,520 admissions in the placebo group. The p-values were 0.22 and 0.42, indicating no significant difference in admissions between the two groups. For the hospital admissions for heart failure, there was 324 patients for a total of 749 admissions for the amlodipine group versus 316 patients for a total of 723 admissions in the placebo group. The p-values were 0.69 and 0.56, indicating no significant difference between the two groups. The study only applies to patients with symptoms of heart failure not due to ischemic cardiomyopathy. The primary endpoint was all-cause mortality. The secondary endpoints were cardiovascular mortality, frequency, and cause of hospital admissions. There is no surrogate endpoints. The number needed to harm was 53 for the overall deaths and 34 for cardiovascular deaths. Since lots of the confidence intervals pass the line of no difference, I cannot say for certain if amlodipine is beneficial or harmful, so I would not recommend amlodipine for treatment of patients with heart failure when the heart failure is not due to ischemic cardiomyopathy.